What's driving excess cardio deaths? COVID, mRNA jabs, lockdowns, NHS overload, or statins are really the answer. Both the UK and the US are reporting record-breaking excess deaths, mainly from cardiovascular disease. Why? That is the big question. What's going on and what can you do to reduce your risk? I invite back Dr. Tess Lawrie from the World Council for Health to enlighten us on all things COVID related, and Dr. Malcolm Kendrick, expert in all things cardiovascular and cholesterol related, to explore these topics with you and point the way forward. Dr. Malcolm Kendrick, a GP who lives and works for the NHS in Cheshire, is author of, among other books, The Clot, Thickens and The Great Cholesterol Con. Dr. Tess Lawrie is the director of the Evidence-Based Medicine Consultancy and author of over 80 published research papers, and is committed to improve the quality of healthcare globally through rigorous research as a founder member of the World Council for Health. Malcolm, I'm delighted to have you back on my podcast. You are my go-to doctor for heart disease. There is now acknowledgement of a big increase in excess deaths post the pandemic, and the finger is pointing at cardiovascular deaths in particular, presumably heart attacks, as the main culprit. What are your thoughts about what could be driving this?
Well, this is thanks anyway for inviting me back, Patrick. Hopefully I can provide some enlightenment. It's a question which is complex to answer. I think, as you said, there's a number of ideas going around. One is that especially in the UK, it's because our health service is overwhelmed and ambulances are not reaching people fast enough. However, we're seeing this same effect in other countries like the Netherlands and the US, where they don't have these problems. So it's difficult to suggest that this is driving it. Then we have, obviously, COVID-19 itself. In fact, when I was writing my book, The Clot Thickens, COVID-19 arrived, and people were astonished to find that people suffering from what was called a respiratory disease was causing cardiovascular disease. At the time, I was looking at influenza A and various other viral and bacterial infections that drove cardiovascular disease. And it seemed to me that exactly the same process was going on here. We had a virus that infects cardiovascular cells, endothelial cells that line artery and vein walls, and because it gets in through a receptor that these cells have, called the A2 receptor. And then once the virus is inside the cell, the immune system comes along and tries to kill that cell, or the virus itself within the cell kills the cell. So it came as no surprise to find we were seeing an increase in cardiovascular deaths, heart attacks, strokes, and blood clots in strange places where you would normally not expect to see them. So there's definitely an element of the viral infection itself causing this. Quite how long after infection it should be increasing the risk is a bit unclear. Then we have the latest thing about vaccines. Now, again, when I was looking at the vaccines early on, there was a concern that we were stimulating the human cells to produce the spike protein part of the SARS-CoV-2 virus. And a lot of the research had shown that it was the spike protein itself that was triggering blood clotting and damage to endothelial cells, myocytes, pericytes, which are in the heart. So I think that there was concern there. I was concerned that this might be triggering some increase in cardiovascular disease. It's very difficult to see the figures here because, unfortunately, there's a great deal of, I'll use the word obfuscation going on about this. And more recently, Chris Whitty and others have stated it's because patients are not getting enough statins, which is why they're all dying of heart disease. I think I'd like to just knock that one on the head as quickly as possible. The vast majority of people who would take statins would be in what we call primary prevention group or low risk group. And there's only been one study that's demonstrated an increase or protection from overall and cardiovascular mortality from statins. Otherwise, there is no protection from statins. So to suggest that thousands and thousands of people are dying because they're not taking statins is incomprehensibly ridiculous, in my opinion. I think that covers my initial thoughts anyway.
Yeah, I mean, that's a very important point to make, that what you're saying, and I know we covered this previously in our podcast, is that statins given to people who do not have pre-existing cardiovascular disease have no evidence of reducing risk of cardiovascular mortality. Is that what you're saying?
That's right. So, and these figures are known to people like Chris Whitty. They must be, or maybe they aren't known to him. So, you know, for him to start coming out with this, it's almost, the problem is that almost everything that people say at the moment with regard to death rates or heart disease or anything, it's got this shroud of you mustn't say anything that could possibly point the finger at COVID or COVID vaccination. So we get these, my tendency is unfortunately to look at these pronouncements and just think, well, this is just the party line, isn't it? You're just coming out with the party line. We need a bit more than this. There are people out here who are not stupid. You need to look at these things and ask the questions. I mean, one thing that I've not discussed is just when COVID started. I looked at the risks of lockdown and the psychosocial upset this would cause, and I was very concerned that we might see a rise in cardiovascular disease anyway, because I looked specifically at when the Soviet Union broke up in the late 80s, early 90s. The countries that were in the Soviet Union, such as Lithuania, a twofold increase in death rates from cardiovascular disease, which is almost entirely considered due to the sort of stresses, the breakdown, the economic stresses, the breakup of a loss of jobs, financial worries, etc., etc. And this was seen in countries like Lithuania, Latvia, Romania, Kazakhstan, Azerbaijan, and Russia itself to a huge extent. So I was very concerned that if we locked everything down and lots of people lost their jobs or they lost their social interactions and children couldn't meet with friends, etc., this would be damaging in and of itself. So I wrote a blog and I did actually predict we would see this jump in cardiovascular disease deaths, which we have seen. So I'm not putting everything on. I think there's a number of factors, but I think one of the factors to me is clearly the gigantic social upheaval and damaging actions that were taken in lockdown, which I think we're now seeing come through. In fact, the Office for National Statistics themselves predicted that we would see 17,000 excess deaths per year for the 5 or 6 years following lockdown due to the economic damage done. That was the government's own figures at one point. I don't know if it still is, but they definitely said that.
So it's, there's clearly this big stress factor affecting so many people in so many different ways. But to sort of understand some of the factors, maybe it'd be interesting, because generally, if we go back to the 80s, cardiovascular deaths have pretty much decreased since the 80s, although that decrease has rather leveled off in the last decade. I think we've already covered, did this have anything to do with statins? But what generally has it been that reduces our cardiovascular risk that might have changed during lockdown?
Well, I remember looking at a study from South Africa where it showed that men who were suffering from financial stresses were 13 times more likely to have a cardiovascular event in the next 5 years than men who were not suffering from economic stresses. Now, you're to say, so how is worrying about your bank balance going to cause you to drop dead of a heart attack? It's actually it's not a hugely complex story, but essentially, put it this way: if you're constantly worried about your job, your finances, or whatever, we'll call it negative psychological stress. The body's unable to distinguish this effectively between that and a lion in the background ready to jump on you. There's still this flight or fight response that's triggered. And if that keeps being triggered all the time and your worries are constant, then essentially what you call your neurohormonal system, the nerves and hormones and everything that control the balance start to break down. Some very interesting work done in Sweden by a researcher called Bjorntorp and Rosen, who actually in the 1980s, early 90s, looked at heart disease in Lithuanian men and Swedish men. it's called the Live-Cordia study. At the time, the Lithuanian men had 5 times the rate of heart disease as the Swedish men. So when they looked at the standard risk factors, heart, blood pressure, cholesterol levels, smoking levels, blood, blah, they were all pretty much the same. But one thing that did characterize the Lithuanian men was they had higher levels of what they called negative stress. When they were subjected to a stress test where you then measure the cortisol levels in response to a stress test, the Lithuanian men showed a very dysfunctional picture. And really, there was clearly damage to their, if you like, their natural flight or fight system. And this was really the only major difference they could find. And when that happens, what happens is, if you are ready to fight or flee, then your blood clotting system is activated because you don't want to bleed when you're attacked. Your blood pressure tends to go up because of narrowing of the arteries. Your heart rate goes up. A whole series of what you like would be functional system effects that would normally be healthy if they happened from time to time. But if they never switch off, you gradually end up with a damaged system. And these people ended up with what you'd call central obesity.
Mm-hmm.
They ended up with what we call insulin resistance, higher levels of type 2 diabetes, and essentially a bit of metabolic mayhem. So if you are under chronic psychological stress, negative psychological stresses, this leads to a sort of breakdown in your system with all sorts of things going wrong. And you can see this again very clearly in people with the most severe mental stresses. What a lot of people don't know is if you are severely depressed, that you can actually develop type 2 diabetes as a result of this. That's a thing first noted in World War I with shell-shocked troops who were constantly under bombardment, and they developed what they called, it was called neurasthenic glycosuria. I can't remember the first term. So yes, the impact of chronic, prolonged, or negative stressors can lead to a breakdown that, if you look through the whole process, it ends up with cardiovascular disease. So the actual system is quite easy, well, not easy to understand, but it's easily understood if you look into it in some detail. So that's where, sorry.
Yeah, no, it's sort of like the word inflammation. If you're in an inflamed state of mind, you end up with an inflamed state of body, and that's that there's a whole cycle of things that happen. And one thing we do know that happened during lockdown was smoking went up.
Yeah.
And I mean, it's interesting, if you look at what's driven cardiovascular disease down since the 80s, do you think there's any evidence that statins had anything to do with that?
Well, there is no evidence. I've looked at paper after paper, graph after graph. In fact, during the 1960s, the rate of heart disease in America, the US went down quite dramatically. And in fact, the authorities had no idea why. There were no statins then. There was hardly any blood pressure lowering drugs. The rate of smoking hadn't gone down. They couldn't really find any factors. So they set up a study called the Monica study, monitoring trends in cardiovascular disease. And they never came to any conclusion. They set the same study up in Europe. And what they found was that they had no answer as to why the rate of cardiovascular disease was falling so dramatically during the 80s. It just did. Interestingly, they could find no correlation between this and the cholesterol levels. So, I mean, if you go back to Scotland in the early 80s, which was where I was, we had the highest rate of heart disease in the world at that time. I mean, since then, that rate has fallen fivefold in young middle-aged men sort of population. But there is no explanation for this. And when a group in Scotland decided to study the 27 factors involved in cardiovascular disease, they found that, again, cholesterol had no impact whatsoever on the rate of heart disease in either men or women, or the rate of death, or anything. These studies, whilst widely available, are virtually never mentioned by anyone. In fact, the number one thing that they found that increased the risk of heart disease in Scotland was having a high fibrinogen level, which is a blood clotting factor. Second to that was smoking. So, I mean, yes, there are certain factors that have come down, like smoking has been very important. Air pollution reduction has been very important. The reduction of toxic metals in the environment has been very important. increased wealth for most people, at least until fairly recently, has been very important. So the factors that we actually don't focus on, such as blood pressure, cholesterol levels, and whatever, are really almost non-existently important. And the ones that are really important are the ones no one even mentions. It's quite extraordinary. I mean, they did we have these risk calculators, as you may be aware. And the one in the UK is called Q Risk 2 and 3.
Yes.
If you look through the risk calculator, it doesn't actually have LDL, or low density lipoprotein, aka bad cholesterol, as a factor that you measure to determine cardiovascular risk. It's not even there. Just to give you some idea of how important cholesterol is.
Well, it's a strange you mention that, because I'm just turning 65, and I went to my doctor, and for whatever reason, possibly to get a few quaff points or whatever, he wanted to test my cholesterol, which was about, I think, 5.5. My triglycerides were ridiculously low, about 0.7 or something. My HDL, was very, very high. And I always liked that ratio between triglycerides and HDL. You may have a different view. And he said, right, you need to be on statins for the rest of your life. And I said, why? And he referred to that, that sort of
risk calculator,
nice approved calculator. And he said, for a man at your age, you calculate at high risk. And I said, I have no high blood pressure, I have no conditions at all. And I asked him, do you know what the NNT, the numbers needed to treat, for a benefit is for a statin, which you want me to take for the rest of my life? And he said, well, good heavens, no, I can't possibly know the NNTs for all the drugs I'm prescribing. And I said, well, I actually do know, and it's fairly close to infinity. For somebody like me. But one of the things here is, if our governments are saying, statins are the answer for this excess deaths, which you can get from your pharmacists, which will at least keep a little burden off the doctors, I think we've already covered that the effect that this is likely to have is zero. But the message it gives, what message does that give to people?
Yeah. Well, the message, all sorts of wrong messages. That essentially you need a tablet to keep you healthy. I mean, there is research that's shown that people taking statins are less likely to take exercise, are more likely to continue smoking, are less likely to do healthy things because they think they're being protected. So in the real world, the impact is probably going to be negative rather than positive. I mean, I would say that some of the studies have shown that statins have had some benefits on cardiovascular disease in those at higher risk, etc. Terms and conditions apply. But the real world study, there was only one real world study done on taking statins, which was not done by a pharmaceutical company. It was called AllHat LLP. And at the end of this study, they found that taking statins had no benefits whatsoever on anything. And the critics said, oh, well, this study wasn't very well done because some people stopped taking statins, some people dropped out, etc. To which I said, yes, but that's exactly what's going to happen in real life. People are not going to religiously keep taking their tablets. So this study was the one that was probably most accurately represented what would happen in real life giving people statins. What was the end result? The end result was nothing at all. And so I look at study, well, amazing coincidence. Only one of the major statin trials was not by a pharmaceutical company. This one was actually run by the National Institute of Health in the States, and only one of those studies has shown no benefit whatsoever. The other 39 or however many there are now all showed some benefit, from vanishingly small to slightly not quite so vanishingly small. So I look at studies like this and think, you know what? The study is the only one you need to look at, and it's the one that says statins are not beneficial. There was a study done in Europe looking at 15 countries and trying to relate statin use to reduction in cardiovascular disease, and that study showed no impact on a population scale across about 300 million people over a period of about 15 years. So, the clinical trials themselves appear to show one thing. The reality on the ground is not well, just completely irrelevant. And, and that wouldn't matter too much from my perspective if they had no adverse effects whatsoever. Just quite a lot of waste of money, I suppose. Although taking statins, it turns people into patients. It's not a good, from my perspective, not a good thing. But if they have got a heavy burden of adverse effects, which I believe that they do, then we're really damaging the overall quality of everybody's life. Tens of millions of people. And I've seen enough people who come to me suffering severe adverse effects from statins that I know what they do. And I know that the clinical trial results do not reflect the real life use of statins, as they can't. Because
is there anyone in the UK health, NHS, government who actually thinks about a real prevention policy?
Hard to answer that, I suppose.
Yes, you maybe don't have to name names, but I remember when Derek Wanless came up with a great recommendation that the National Health Service was not a health service; it was a sort of disease management service.
Yeah.
And something needed to change. And I suppose another way of asking you that is, as a man who's spent his career working within the NHS, and while I totally respect the overload of doctors and nurses and the essential work they do on low salaries, is more money, more nurses, more doctors, more drugs ultimately going to solve the burden of disease, or is it just going to cost the nation more?
Well, I think one answer to that is around about 2006-07. In the UK, we introduced a thing called Quality Outcome Framework, which you may have heard of. Most people have no idea it exists, although GPs can certainly tell you about it. It's essentially, there's a very large amount of payment, about a third of the GP's total.
This is the QOF system.
QOF, Quality Outcome Framework. Is based on reaching certain targets, lowering blood pressure to a certain degree, lowering cholesterol to a certain degree, getting blood sugar under control, measuring this, measuring that, measuring the other thing. It's a gigantic preventive medicine exercise, the biggest and highest scope ever anywhere in the world has been done. So
has it worked?
Well, the answer is that the life expectancy in the UK prior to COVID was beginning to fall. So you have to say to yourself, if we have this gigantic, enormously billions and billions of pounds, huge amount of time and effort spent on this in this preventive system, the most comprehensive that exists, and life expectancy is falling, then your primary outcome, the one you're most concerned about, is going in the wrong direction. So you'd have to say is, well, maybe there was other things that have caused this, although I have no idea what you might think they might be, because less people are smoking, there's less pollution, da-di-da. People are generally supposed to be healthier. And yet life expectancy is falling. So I think the simple answer is, well, clearly it hasn't worked, isn't working, and yet they've got rid of it in Scotland, by the way. In England, they still cling to this as though it is some magical thing that means that we'll all be fit and healthy. Well, sorry guys, it ain't working, is it?
Now, I heard, I'm not sure if this is true, that this QOF, system had cost about £30 billion, and something, a big chunk of that was paying doctors more, and a big chunk of that was, more drug prescriptions. And I heard that some doctors, 20% of their salary is coming from this system.
No, it's more than true. It's GPs, 30% of your salary is dependent on the system.
So every time your doctor asks, to measure your blood pressure, measure your cholesterol, measure these things there, and then lower it, which of course statins will lower your cholesterol, they're getting paid, basically.
Yes, they are.
Yeah.
This is payment by target-driven preventive medicine. I mean, you can't blame somebody if 30% of your salary is dependent on doing this. You'd do it as well, wouldn't you? Well, 30% of the income of a general practice, which is not 30% of your salary. If you lost 30% of your income for your general practice, you would have no profit at all in your general practice. You would make no money. You would be working for nothing. So if you got rid of, because obviously GPs employ other staff and they pay for this, that, and the next thing. So if say off the cuff, I mean, just making this figure up as an example, if the practice brought in £1 million, right, of income from doing various things, approximately 300,000 of that would be the money that the partners would then take as their income for that year.
Mm-hmm.
If you got rid of that 300,000, then there would be no profit for the practice. There would be no income for any of the partners. So the reality is, if you got rid of QOF tomorrow, no GP would have a salary, or would have a salary to take profits. No GP would make any money. And
I had a good example of this with in my sort of pet subject of dementia prevention, where high blood pressure is a risk factor. Therefore, why not lower it? And the most recent study, which gave aggressive hypertensive medication to lower blood pressure to 120/80, that's the logic, and it's prevention, so to speak. It produced one less case of dementia for every 1,000 taking the medication. However, there were, I think it was 337 SAEs, serious adverse events, which means death or hospitalization, out of the 1,000. But of course, here we have a situation where high blood pressure actually is a risk factor. Well, I think what you're saying is that even high cholesterol, certainly up in the sort of probably up to 6 or 6.5, isn't actually a risk factor. We assume it's a risk factor, but
I'm just going to stop you there. It's not a risk factor, no matter how high it is. But
okay,
carry on.
Yeah, all right. No, that's good to hear. So my final question to you is, if you were health minister, what would you do? I mean, what would you focus on, especially in this incidence of excess deaths and cardiovascular disease?
Well, I mean, you probably know the answer is not what they're going to do. I mean, I would say, let's open the books and have a look at it and do a proper review. But don't make 50% of your research out of bounds for anyone to look at, because we have to know what's doing this. There are people, this is a world where true conspiracy theory grows, is if you are clearly hiding things and clearly not allowed and not allowing anyone to discuss. Something is causing this.
Yeah, what is this hidden evidence? What is it that we really need to have an objective, open look at?
Well, we need to look at. One of the things we need to look at is obviously we've had a couple of very major things have happened, haven't we? We've had a COVID-19 pandemic. Is the death rate due to this? The problem with this being that you immediately run into people scurrying around and trying to not tell you how many people have been vaccinated or not vaccinated, how many people actually had the infection or otherwise. So you have a big kind of gray areas and no-go areas to look at, which are, for instance, vaccination rates and infection rates. And it's almost impossible to find these data out. And then, to me, it seems clear that this stuff is actually being hidden from people to see. Now, maybe there is nothing to see, but by golly, why not let people? Are we to be treated like 5-year-olds who are not trusted to see the facts or the true situation? This is the exact opposite of scientific debate. This is, we know best, you can't see it, we're not going to show it to you, and anyone who cares to actually ask for the correct data is going to be hounded and attacked. I mean, this is just terrible stuff going on at the moment. Unbelievable stuff that's going on at the moment. It's outrageous. I have one thing that I'm interested in, is trying to find the truth. And when I find that I've got big barriers and doors shut, then my natural inclination is to want to know what's behind those doors, because that's where I think the answers lie. And if we keep these doors completely and firmly shut, we're never going to get the answers to what the hell is going on, are we?
Malcolm, thank you very much. My next guest, Dr. Tess Lawrie, is going to talk about exactly that.
Okie dokie. Nice to speak to you.
Now, I'd like to address the elephant in the room, and that is the possibility that mRNA vaccination adverse effects is one of the contributors to the excess deaths and increase in cardiovascular deaths that are being reported. It's very hard for anyone employed by the state, be it a GP or MP, to address this issue, albeit purely on scientific grounds, without reprimand. So I'm delighted to have a pinnacle of evidence-based medicine, Dr. Tess Lawrie, who, prompted by the COVID crisis, established the non-profit community interest health and research company. It's called EBMC squared, but evidence-based medicine is what it's all about, in 2021, and co-founded the World Council for Health. Now, the mission statement of the World Council of Health is a non-profit initiative for the people that is informed and funded by the people. Our global coalition of health-focused initiatives and civil society groups seeks to broaden public health knowledge and sense-making through science and shared wisdom. We are dedicated to safeguarding human rights and free will while empowering people to take control of their health and well-being. So, hello, Tess. Welcome back.
Hello, Patrick. Thank you for having me back.
It's a pleasure. Last time we spoke, it was about the science of ivermectin and the treatment of COVID. The science was there, but still, I don't believe we are able to get that prescribed. Is that true?
Yes, that is true. We're still really, tackling the MHRA and trying to get this really cheap, effective, and safe medicine made available to the public.
Yes, sheep can get it, but not humans. Today, we are addressing any possible role or concerns about repeated COVID vaccines, and especially mRNA vaccines, in relation to the excess deaths, and especially cardiovascular deaths that we're seeing both in the UK and abroad. But let's first get some background. What is an mRNA vaccine, and why could it potentially be a problem for some?
Yeah, well, an mRNA vaccine is not the same as a traditional vaccine. That's the first thing everybody should know. And unfortunately, this hasn't been widely shared. An mRNA, a traditional vaccine, you get a piece of the virus dead or attenuated, it's called, so it doesn't work, it doesn't cause harm, or a piece of its protein, and it's a finite amount of viral substance that gets injected into the shoulder muscle, and your body makes antibodies to that finite amount of viral material. The mRNA vaccine is something completely different. It's a technology that has never actually been proven to be safe in the context it's been used now, and in actual fact, it consists of a genetic code. So it's a genetic code is like a recipe to make a protein. So instead of it being a finite amount of protein, it's a recipe that uses your body's apparatus, your cellular apparatus, to actually manufacture the viral protein. So I'm sure, if anyone would be thinking, well, why would I want to make a viral protein? Well, according to the manufacturers, the theory behind it is that this viral protein that your body makes generates an immune response. And then when you get exposed to the virus, your body has the immune response to fight the viral protein. There's a little flaw in the basic theory of this, and that is how much of this viral protein does it make? Well, nobody seems to know. So what happens? And also, does it stay in the shoulder muscle? No, it doesn't. So in actual fact, what we have is a substance that's called a vaccine. It's actually a genetic therapy. So it's a piece of gene code or gene codes, trillions of copies of this gene code that get injected into the shoulder muscle. Instead of staying in the shoulder muscle, their studies show that it circulates around the body very rapidly in a couple of days, hours to days, and it gets taken up by the cells of one's body. Then you have trillions of cells making this, using the cellular apparatus to make a COVID virus spike protein. Your body then gets its T cells and antibodies to the spike protein, but unfortunately, the spike protein is actually in your own cells. So your body makes antibodies that are then targeting the cells that are making the spike protein. And so it's really far from an ideal situation, because we don't know how long We don't know how many copies of the spike protein it's making. We don't know how long the body makes the spike protein for. And we don't know what happens with all this excess spike protein that is made. So you said, why could it potentially be a problem? Well, you get, firstly, you get an inflammatory reaction set up, something like myocarditis, pericarditis. The itis in that word means inflammation. So, so you get an inflammatory process set up, and because any cells of the body can be making the spike protein and having this inflammation, it's not just the heart that can be affected by inflammation. Any tissue can be affected by the inflammation. So it's not just, so it's the protein that gets deposited, which is a problem as well. If you're making a lot of the spike protein, where's it going if your body can't break it down quickly enough? It goes into the tissues. It goes into the lining, the interstitial tissues of the blood vessels. And equally, with the multi-system inflammation, you get blood vessels that are, around the body that are affected, that are making and showing the spike protein and setting up this inflammatory process, which also leads to clotting.
Mm-hmm. And I mean, we've seen catalogued a number of cases, probably thousands of cases now, of myo and pericarditis, so that's inflammation in heart tissue, as an official vaccine adverse effect. But you're pointing out that inflammation, sort of post-vaccine, can occur in any organ of the body.
Yes, absolutely. If you look at the yellow card scheme data, the official data, if you type in, well, I'm not even sure you can't type it in any longer because they're no longer making the data available. But anything with itis, so there's myocarditis, pericarditis, encephalitis, myelitis, anything with itis suggests inflammation. And so, that is what you're seeing. And then also clotting and hemorrhaging. So there's a lot of clotting, bleeding, ischemic kind of conditions. But if the heart's affected or the brain's affected, well, then it's going to be more dramatic. Then you're going to see, you're going to see, those are the places where one's more likely to see sudden death. Or death,
Mm-hmm.
But if it's a nerve or muscle, or hepatitis or gastroenteritis or inflammation of the ovaries, that's going to present in a slower way, perhaps as infertility or autoimmune diseases, cancers, and so on.
Now we have, the sort of official number now, I think, is 50 coroner's reports where the vaccine has been deemed to have caused a death relatively rapidly after vaccination. But of course, what we're looking at now is a lot more excess deaths. At the other end of the scale, one of my colleagues works for an undertaker here in Wales, and he says we have never seen this level of deaths, and it's across younger age ranges as well. So the undertakers are certainly, working flat out right now. So why do you think vaccination could be contributing to these increases in deaths?
Well, as I said, there's multi-system inflammation. I'll just actually take you back to June 2021. We at EBMC Squared, we did an analysis of the UK yellow card vaccine adverse event data at that time. And we sent an urgent report to the MHRA and June Rain to say, these vaccines are not fit for purpose. They are causing a lot of harm, and you need to start preparing for a lot of harm and ameliorating the effects. And this was because we looked at the data, and we looked at bleeding and clotting and ischemic disorders, and we saw that the majority of deaths were coming from brain clots, lung clots, pulmonary embolus, heart clots, cardiac arrest, and so on. But we also saw a lot of other harms, so neurological harms, which are much longer. So a huge number of those. So there's clearly a huge amount and a huge range of non-specific disease that's associated with these mRNA injections. I don't even want to call them vaccines anymore because they are so different from the normal type of vaccine, and it's that very nomenclature that has sort of deceived people into thinking that they're as safe as regular vaccines. We see many reasons, many different types of diseases on the official yellow card database that are just not being talked about. There's been this focus on cardiac events, but in fact, neurological events are far more numerous. The UK scheme has about 500,000 reports, so 500,000 reports of harms. And if you actually look at those data, most of them are serious. They give a percentage of things like 70% of the harms are serious, and they are across the board. There are children, thousands of children who have adverse events reported on their behalf. They are, it's not limited, as you say, it's not limited to a particular age group. In fact, the majority of adverse event reports are in the age groups 30 to 39, but basically that 20 to 60 age group is the group that has the hundreds of thousands of adverse event reports, and the official narrative is that these vaccines are safe and effective, and nobody is talking about them. I feel so sorry for the public. Sorry, I just want to say,
yes.
It's no one is being frank. No one is just speaking the truth.
Yes, it seems very hard to do that these days. Is there also a concern about the number of vaccinations? Because normally in a sort of regular vaccination, there's a lot of learning about whether you need one shot and then a booster and what the spacing is and so on. But here we seem to be, into round 4. I think there's much less uptake of the 4th booster. But is there a concern about the effects of multiple vaccinations? Is there any evidence of that being worse? Is the benefit, any better by continuing down this path of booster? What do we know about that?
Okay, so I'll tell you about one study, and the rest really just has to be common sense. I think most people know that they've never in their lives been told to take so many jabs for the same disease in such a short space of time. So I think the alarm bells ringing there anyway. Most people have realized there's something really odd about this new vaccination regime. If you consider that each injection gives your body this recipe to make spike protein. So it's making a spike protein, your cells are making the spike protein, and then you have your immune system stimulated to fight this spike protein. And it does that, and then just as it's sort of starting to get balanced, it gets another injection, it gets activated again. So it's a constant stimulation. The more injections you have, it's a constant stimulation to make the spike protein and then to fight it. And you can imagine that's quite exhausting. So after a while, your body actually becomes exhausted. And so instead of increasing your immunity, your immunity is focused on fighting this one thing, and your immune system actually becomes depleted. And so when something else does come along, because remember, your immune system is used to fight cancer as well. So another infection comes along, COVID comes along, because COVID's been, the virus has been changing, and the vaccines haven't been adapting to the change, or you have a susceptibility to cancer, or you have you're in remission, then your immune system is needed to step in at all those times. And if it's busy and it's preoccupied trying to make and fight the spike protein, it's not going to be available to protect you. So in actual fact, you get an overall reduction in the functioning of your immune system. So the more injections will definitely not protect you and will worsen your immune system. And just to say that there is a paper, because there's a lack of studies, there have been no studies, and this is exactly where we need to be asking our regulatory agencies, where have they been? What have they been authorizing these injections on? Because the evidence is not there, and there's certainly no evidence on these boosters being safe and effective, being rolled out more and more and more. There is one study done in mice which shows that after 4 injections, the overall immunity is severely reduced. And that's what we have to go on. So it's really unacceptable that we have no research and we have these politicians and agencies saying safe and effective, take another one, and it really is criminal.
So what do you think should be the policy of governments going forward right now?
Well, they need to acknowledge the harms that they've caused by their policies, because the lockdowns and everything were absolutely harmful to society, communities, individuals, and they need to repeal all of these policies. They need to acknowledge the role of natural immunity. They need to do they need to do the studies. They need to do audits, transparent. In fact, they should let independent organizations do these studies and have access to the data, because they're being very they're keeping all the data to themselves. They're not sharing those data. We need to have access to the death rates and birth rates, etc. They need to contact independent professionals to give opinion, and also how to treat, because so many people are injured. We need policies on how to treat people with COVID vaccine injury. We need research into people who are experiencing COVID injury. They need financial assistance, medical assistance. We need public awareness campaigns to tell everybody, look, this is what we found. So instead of the BBC just speaking about, the distractions that they do speak about, we need some real honest reporting, and we need awareness campaigns to teach people how to boost their immunity, optimize their health, and so on. So we need public engagement. We need open forums where people can express themselves, where both doctors and people who've been injured, we need to be able to have open discussions now. So is that enough? No vaccine passports. No, that's absurd.
Yeah, no vaccine passports. And yes, the World, the World Council of Health covers a lot of this. What to do, how to protect yourself, and we will give out the details and what you can find at that website in a minute. You mentioned natural immunity, and of course, that's what I've spent the last couple of years trying to promote. It's literally, a good half of your whole immune system. There's your innate natural immunity, which is the first line of defense, and then we have our learned or acquired immunity, which is where vaccines or exposure to a virus comes in. So we're talking about building your own natural immunity, your own terrain, so to speak. We're talking about vitamin C and vitamin D and zinc and other such things. And we actually got to the point with the National Institute of Clinical Excellence, who have a specific group called Rapid C19, whose remit is to rapidly find safe and effective treatments in this area. And they acknowledge that there are over 20 clinically relevant studies on vitamin C. These are the studies that we've largely sent them. And they agreed finally to circulate them to other agencies like the Department of Health. We happen to get the minutes of the Department of Health's group called Scientific Advisory Committee on Nutrition. and they list all the papers. So, these papers are not denied in any way, but they are told, this is the Department of Health group, not to review them. Why? Because NICE is Rapid C19 group. It's their responsibility. And they have told us in a Freedom of Information Act request that they have not reviewed them. So we have government agencies sitting on accepted scientific data on vitamin C, on vitamin D, on other ways to boost natural immunity, and they just are not even bothering to review and share that information. So we are in a shocking period of time where data is being hidden, and I think that's awful. But the World Council of Health, tell us how people can access the wonderful information and get informed, and in a way take responsibility, take charge of their own health. What can the World Council of Health offer people, and how do they access that?
Thanks very much. Well, the website is worldcouncilforhealth.org, and you can access health guidance in a number of ways. And it's really, what we're really trying to do is empower people to take responsibility for their own health. So we're not saying we're the gurus. We are a grassroots organization. Ultimately, we have partners in 46 countries, 170 organizations, and climbing every day. And it's really about especially in this field of new diseases and new diseases associated with vaccine injury, and the need to get healthy is more important than ever. We draw on our grassroots organizations to inform us, and we put that information forward to the public to do with what they will at their own, based on their own research. And so we have a detox guide. It's been there for I think almost probably around 9 months or so, and it's in the process of being updated, because as new information comes in, we are updating it. And that's for people who wish to detox from the toxic the environment and the injections. And also we have a at-home COVID treatment guide, but you will also find a lot of resources to do with communication, mental health, mind health, and we really want people to empower themselves and realize, if one thing we've learned from COVID is you can't outsource your health to the government or to your doctor, you actually have to engage every day and get into a healthy rhythm, have a strong immune system, and as I say, don't outsource your health to others. We have a number of ways you can get involved as well. There's leafleting, information for people about the jabs, where to go. We have some partner organizations like UKCD Family, which is a support group for vaccine injured people, and also React 19, which is a US-based organization, and they have a lot of resources. So you can also on the website explore our partners. And the other thing is, if you need just some uplifting reading and sort of weekly guidance, I have a podcast called Tess Talks, and a Substack, which is a better way to health with me. And it's really just sort of taking people on a more sort of optimistic, empowering journey to learn about all the other integrative health approaches. There isn't only one way of getting healthy, and that's through getting diseased and then taking pills. There's a whole range of things one can do before one actually gets disease. And so this is a journey that I'm hoping people will join us at World Council for Health on, and really step away from fear of sickness and death, and really into a healthy, better way of living.
Well, thank you, Tess, Dr. Tess Lawrie, a very honest and scientifically based appraisal. Thank you so much for your wisdom, sharing this information, and also your courage. And I'd also like to thank my first guest, Dr. Malcolm Kendrick, a GP, who explains why statins are not the answer. So we have explored what's driving excess cardiovascular deaths. We've spoken about COVID mRNA lockdowns and the effects they've been having. We know that statins are not the answer, and it sounds like repeated vaccinations also is not the answer. And we need to strengthen and learn how to boost our own natural immunity. So thank you very much for listening.